Now let's move on to the second topic of today, monitoring in type 1 diabetes. To speak on this, we have Dr. Tushar. Dr. Tushar is a director of Harmony Health Hub, Nashik. He is associate professor in Dr. Vasant Rao Pawar Medical College Hospital, Nashik. He has contributed to book chapters in pediatric and pediatric endocrinology, and was an executive board member of ISPE. And he has received Sarla Vaishnavi Award for Best Research Paper in Metabolic Diseases. He has few publications in national and international journals. Over to you, Dr. Tushar.
Thank you. Thank you so much, Dr. Vani and Dr. Monica, and thank you organizers for giving me this opportunity. So in next 25 minutes or so, I'll be taking you through the aspects of monitoring. If you give me the permission to share the screen.
Okay. Sir, does permission? All panelists. Yes, sir.
Yeah.
So you can share your screen.
Yeah. So we are going to touch upon various aspects of monitoring a child who is having diabetes and is under your care. So I understand most of us, the delegates in the in this CME are pediatricians. So I've put these slides very basic and simple, and I would want to touch upon various aspects. I hope my screen is visible.
Yes, visible.
Yeah. So all of you are very expert in managing diabetic ketoacidosis. In India, most of the children do come to us in a state of moderate to severe DKA, and our intensivist colleagues, our pediatric colleagues, are very well versed with treating these children with diabetic ketoacidosis. And then these children are often cared by various physicians, or for that matter diabetologists, and unfortunately not every child receives the treatment that is ideal. Many of them do not have the tools or education for monitoring their own sugars, and the reason is multifold. Maybe affordability, maybe lack of education, but most importantly, the physician or the pediatrician or the endocrinologist, if he or she is not tuned to seeing children with diabetes, then the patient education is not adequate, and that's the reason most of the patients, after initial few months, they stop monitoring their sugars, they stop caring for their diabetes. And what does this lead to? Let us see an example. So she's a 15-year-old female. She has been struggling with diabetes over last 10 years and having suboptimal sugar control. Nowadays, we don't use the term as poor control because it's derogatory. So we use the term as suboptimal control. Look how she's walking out of my clinic. So she clearly has diabetic retinopathy, and look at the condition of
Sir, we are not able to see you or hear you.
Like adult diabetes fashion, and they do not monitor, and the result is micro and macrovascular complications. One more example, these are siblings, 16 years old boy and 13-year-old girl. Both of them are type 1 diabetic since the age of 5 or 6, and look at their heights. Their heights are severely compromised, and the reason is suboptimal sugar control. So as their sugars have not been controlled very well, and the education part is lacking, they ended up being very short. This poor girl also had tuberculosis as a result of poor sugar control and poor immunity. So this is the end result of poor sugar control. And to prevent these scenarios, one must monitor these children carefully for various aspects. Sugar control is very important to prevent complications. This slide is very old, almost around more than 20 years old, and here you can see as the HbA1c, or the percentage of glycated hemoglobin, rises, indicating poor sugar control, the chances of getting retinopathy, nephropathy, neuropathy, or for that matter microalbuminuria, the relative risk goes high in logarithmic scale as your HbA1c goes beyond 7. So this is the importance of monitoring these children for their sugar control. So in next around 15 to 20 minutes, I'll be discussing on the monitoring for sugar control. Under that heading, we have the self-monitoring of blood glucose, the continuous glucose monitoring system, and HbA1c. Monitoring for danger signs, and in the end, monitoring for various long-term complications of type 1 diabetes. So first section of my talk is monitoring for the sugar control of blood glucose is the core or central pillar of your sugar control. No matter how costly insulin you are giving, the previous speaker, Dr. Ahila ma'am, was elaborating on the analog insulins. Yes, insulin choice and insulin quality matters a lot in control, but more importantly than the choice of insulin, it matters how intelligently are you delivering the insulin. And to know how much dose of insulin is required, what you need is self-monitoring of blood glucose. So if you go through the recent ISPAD 2018 guidelines that were published in Hyderabad, these guidelines mention that the recommended frequency is 6 to 8 times per day in order to know your pre-prandial sugars, your prandial sugars, your bedtime sugars, and your midnight sugars. Ideally, they have to be done at different times of the day. Now, looking at this frequency, every one of you must have found that our patients are not motivated enough, and they are not economically sound enough to spend 6 to 8 glucose strips per day.
Sir, I think
Pre-prandials.
Yeah.
Sorry.
Sir, your network was interrupted.
Okay. Is it better now?
Yes, sir, it's better.
Yeah. I'm putting my video off to save the bandwidth.
Okay.
So the ideal is pre-prandial every day, and post-prandials maybe 1 to 2 times in a week. But then we have, all of us face this economical burden, and we have devised something called a 7 sugars a week method, where they are supposed to check sugars at different times of the day in pairs. So on one day they will check pre and post breakfast. On the subsequent days they will check pre and post lunch and pre and post dinner. Type 1 diabetic. If your patient is unable to afford the SMBG frequency below this, you may cut down on the insulin quality a little bit. You may shift them to a more basic insulin, but rather insist them on SMBG. So fasting sugar and PP sugar, that is taught in adult medicine, and for type 2 diabetics on insulin, fasting PP sugar is not good enough. You have to do SMBG, and you need to check at different times of the day. That's extremely important, because adult diabetics often have this is ideal? There is no one answer to that. More you check, more better sugar control you get, because more opportunities are available for you to correct on their low or high sugars. So this is one study that I'm quoting from 2011, where the typical frequency of children on SMBG, type 1 children between 0 to 18 years, was shown to be 3 to 4 times in a day. And this study was over 10 years, and they showed that in this 26,000 odd type 1 children, the SMBG frequency, as it goes up above 3 to 4 to 5 times in a day, the HbA1c drastically comes down. So more number of SMBG pricks your child does, better is the resultant sugar control. And this we know since last multiple years. When to test? So SMBG, fasting sugar is required to decide the basal coverage. The insulin glargine or detamir or insulin you are giving, the dose will be guided by your fasting sugar. Pre and post meals, often checked in pairs, they give you an idea about the meal bolus, the insulin that you give for your food, whether it is adequate or more or less, and is your insulin profile matching with your meals. That is, you get that idea out of your paired sugar readings. The bedtime or midnight sugar reading especially is important for children who have had severe hypoglycemias in the past, or any children who are below 5 years that have hypoglycemia unawareness. So smaller children will not tell you that my sugars are going down. And that's the reason we check bedtime or midnight sugars once in a while, probably once in a week or once in 10 days at least, for children below 5 years, to know that their midnight sugars are in a safer zone. At the beginning and after a few hours of exercise, to know what is the effect of exercise on the sugar. No matter what your instinct says, always prick your child and see what is the sugar. Please confirm that hypoglycemia on the glucometer, and then check again after the recovery from hypoglycemia. These are typical sugar logs. I'm not saying that this sugar log is ideal, but this is one of the methods with which the patients monitor their sugars. This is an old record that I'm showing you. Here, this particular child has checked the pre-breakfast, pre-lunch, and pre-dinner sugars, but this particular family has not documented post-lunch, post-dinner, and mid-time or the bedtime sugars. So here in this sugar log, what is good is they have done something, they have documented good sugar log, but what can be done better here as far as monitoring of sugar control is concerned is this child, in addition to what he has done, can also check the post meals, post lunch, post dinner, and midnight sugar. That's the additional information that you would ask this child or this family to document. This one patient is not an affording one, but still making an attempt to check the sugars and documenting. So one should be always be encouraging them that, okay, you have done this, you have monitored your sugars, you have brought your sugar diary, very good, but now let's work more on understanding what is going wrong in this. So here we can sit with the patient and analyze the individual sugar records. SMBG is to measure the sugar, to the sugar, and to react on the sugar. And it's a continuous process where it's a ongoing cycle of measuring, documenting, analyzing, and reacting. So SMBG is in fact smartly managing blood glucose, and this has to start right from the diagnosis, and it's an ongoing process. There can't be any excuse to not check your own blood sugars. What are the things to consider to be considered before you prescribe SMBG to any patient is the cost per strip. So now there are multiple glucometers available in the market, and the strip cost is what dictates the frequency. So the standard machines, the ISO certified machines, typically have the strip cost anywhere to the tune of 14 or 15 rupees per strip. The testing frequency also will guide you regarding which SMBG or which glucometer is to be used. Amount of blood required for children or infants or children less than 2 or 3 years. the parents are very anxious about the blood loss, and you need smaller lancets, smaller pricks, and smaller blood drops. So the machines that give you readings with a smaller drop of blood are to be preferred in smaller children. Accuracy. Now, every machine will have an error margin of around 10%. So it is acceptable to have a glucometer sugar of 90 and the blood lab value of 100. There is no need to panic if there is an error margin of around 10% or sometimes 15%. But then if your accuracy is going beyond that, memory. It's extremely important for your patient to have a glucometer that has got a memory, and most of the good companies or good glucometers will give you the memory over last 90 days. There is absolutely no role of prescribing a cheap glucometer that does not have a memory, because your patient has to reproduce the readings to you when you reassess them. So you have to go through the machine readings, and in order to do that, the machine has to have a good memory. And there are nowadays facilities to connect these glucometers to computer. In my clinic, we have the facility where the patient downloads the data and sends me over the email, or we connect the glucometer to our system and we pull the data from the glucometer. So what are the targets for blood glucose when you are monitoring the blood glucose on an SMBG or CGMS for that matter? ADA 2015 gives fasting of 80 to 130 and postprandial any sugar below 180. ISPAD, on the other hand, permits a fasting sugar of around 70, 75 or 80. That is normal for fasting. The range is up till 130. The postprandials are 90 to 180, and the bedtime sugar is recommended to be 80 to 140. This bedtime sugar is very important for smaller children because the parents keep on overfeeding these children in the fear of hypoglycemia. So you can tell them that check bedtime and midnight sugar maybe once in a week, and stop overfeeding these children in the fear of hypoglycemia. So now one has to read in between the lines. Sometimes they come to you with very good sugars, but the frequency is very low. This is a particular example where the child has tested very less. He has in one small page he has covered 2 or 3 months. So this is not acceptable. The minimum frequency of testing has to be considered. How do we analyze these SMBG records? So this is a perfect example where the patient corrected for the high sugar by giving 1 unit extra. Should have corrected, actually he has not corrected. And the second example is, many of them feel that eating Karela or any vegetables can give rise to low sugar. So here he actually took less dose for that Karela sabzi, and see the result is the sugar actually went up post Karela, because the child likes Karela sabzi and he eats more of chapati or bread with that sabzi, and the result is high sugar. So we can learn a lot from these SMBG records, and if we sit with the patient and explain it to them, then there is a lot of learning opportunity in these SMBG logs. Nowadays, what I practice in my clinic is, most of my patients have the applications such as My Sugar app, where they record their own sugars in their mobile devices, and they can export the data, either monthly data or the 3 monthly data, and this is the kind of report that we get. So this is my recent patient where the sugar logs we checked, and the sugar control was actually very good. The estimated A1C is calculated by the glucometer. You can get the average sugar, the deviation, and the percentage of readings that are in the hypoglycemic range and the hyperglycemic range. Here you can see between these 20 days, the child has checked 30 sugars. So at least there is 1 or 2 sugar readings every day. Although we encourage these patients to check more, but then you have to accept the frequency that the patient and the family is ready to comply with. So this is the graph that you see in this My Sugar app, and these apps are very handy. And nowadays the glucometer can communicate with the mobile phone via Bluetooth, and you need not actually maintain a physical diary, but just link your glucometer with the phone, and all the readings from your glucometer will be converted to your PDF inside your phone. What is a CGMS? CGMS is a continuous monitoring of blood glucose. So it's a device that is stuck to your skin, and there is an electrode inserted under your skin. Dr. Ahila showed a picture of that. So CGMS gives you access to unlimited information. So you get minute by minute sugar, or sometimes every 5 minute sugar. But then you have to understand that these CGMS sugars are in fact the past. There is a delay of around 11 to 15 minutes between the blood sugar and the interstitial fluid glucose. So whenever you are reading the real-time sugars on your CGMS device, one has to understand that the hypoglycemia that you are seeing right now on the CGM had happened some 15 minutes ago. And if you have already given some correction, then you have to wait for additional 15 minutes. If you have consumed glucose for that hypoglycemia, don't be blinded by that CGMS reading, because it's a 15-minute old reading. So these small things you have to consider when you are interpreting the CGMS values. The real time gives you the predictive alerts. So the real time CGM will alert you before the hypoglycemia happens, and you get alarmed and take corrective action, either reduce your basal insulin rate or take some small snack to prevent the hypoglycemia. There are recorded CGMs that are cheaper, but they give you good amount of information retrospectively. So you can put the patient on a CGM device that is a recorded CGM, and later on you can pull the data, download the data, and sit with the patient with the food diary and analyze what food caused this spike, what activity caused the hypoglycemia. So even if your patient cannot afford the real-time CGMS, the recorded CGMS gives you plenty of information to work on, and eventually you can achieve better sugar control via this recorded CGM system of glucose monitoring. One example, this particular patient of mine was very afraid of hypoglycemia. He had a hypoglycemia some months or years ago, and after that he is afraid of increasing his glargine insulin. So we just merely put a CGM on him, showed it to him that the entire night you can see different colored graphs, different colored lines depicting various days. So all his sugars are above the target range. So he's spending all his nights in hyperglycemia, and only between 6 p.m. to 8 p.m. his sugars are coming down. So this hypoglycemia was actually happening because of his exercise, and this CGMS record gave us the exact clue that the hypoglycemias are happening because of the exercise, and rest of the sugars are high. So here we could convince the patient to increase the glargine insulin dose and take a small snack of a small snack just before the planned activity. HbA1c, I need not tell you more. So HbA1c, your SMBG readings can lie, but HbA1c will generally not lie. But then there are also problems of HbA1c. HbA1c is an average. So if you have very high and very low sugar readings, then there will be averaging out. So you should not simply rely on just the HbA1c, but also look at something called as time in range. On sick days, what you have to monitor, you have to check the sugars more frequently, take extra doses. There can be a separate topic on sick days, so I'll not spend much time. Earlier days, we used to check their urine ketones via these urine ketone strips, but nowadays we don't rely on urine ketones anymore. We use something called as blood ketone. So we have this beta hydroxybutyric acid, the blood ketone strips, and they are easily available nowadays, and they detect the ketosis early and the recovery also very early. You need not rely on the urine ketone strips. So this is the blood ketone meter that is available, and it should be made available to every child who has had multiple episodes of ketoacidosis. These are the monitoring that has to happen in the clinic. Just don't believe SMBG readings, but also go through the glucometer, because sometimes the glucometer shows you entirely different readings, and you later on recognize that the sugar readings were. So here, instead of scolding these children, you take them into confidence, understand what are their problems, sit with them, do a good amount of counseling, and tell them that will not scold you for high sugars, but rather we can help you achieving better sugar control if you write whatever sugars are there in the glucometer. These bad sites, every OPD visit, Rather than just looking at the SMBG logs, you also have to see the sites. Sometimes they come to you with such bad sites. There are problems of prescription, and the prescription says something and the practice is something really different. These are the sizes of needles, and patients can sometimes get confused between the syringes and needles and the pen devices. And we have had such problems of using insulin via a cartridge, that is 100 units per ml of insulin being used with a 40 IU syringe. This is not my patient, but this patient landed up in hypoglycemia. So I saw this patient in ICU and I realized that the patient is taking wrong insulin in a wrong syringe. Children are very smarter than we think. We must educate the children. Many of the times we spend a lot of time with the parents, but rather we should educate the children. It yields you better results as far as the sugar control is concerned. What is a CGMS? We just saw that the the SMBG gives you the snapshot of that sugar, but the CGMS gives you the trend between these sugars. So what has happened before and after that sugar is captured on a CGMS. What is time in range? So this is a newer concept. So time in range is now harped upon by most of the professional guidelines. So rather than just going by the HbA1c or the SMBG records, you should see how much time the patient spends in that range, and it is extremely important to have good time in range. So in order to do that, the patient has to spend at least 70% of his time in the normoglycemia range, defined as sugar between 70 to 180. And it has been validated on various data, including the DCCT trial from 1993, where the time in range is associated with lower risk of microvascular complications, and time above range are associated with more number of complications. Growth monitoring is extremely important because many of the children with diabetes end up being very short. They have delayed puberty. Many of them, if they are on premix insulins, twice a day insulin, that we highly discourage. We encourage the basal bolus insulin, but many of these children are still being given premix twice a day insulin, and these are the children who don't monitor their sugars and end up having these problems of short stature, delayed puberty, hepatomegaly, and sometimes they are also seen with Cushing-Boyd features. So this particular entity is called as Mauriac syndrome, and it's not rare. It's quite common. In fact, when we see children on twice a day insulins without any monitoring, they end up having this problem. In one particular study, it was shown that around 11 to 15% of children with diabetes from India end up being short, and the reasons are poor IGF-1 generation because of less of insulin, calorie loss through the glycosuria. So if the sugars are not controlled, they'll not get good amount of calories to grow, and as a result of that, the proteins will be burnt for calorie generation and resulting into poor growth. Restrictive diets are also one important cause for poor growth, and the comorbidities that should be monitored for are hypothyroidism and celiac disease that can also contribute to growth failure. These are the growth charts that we encourage all the pediatricians to use. Blue is for boys and pink is for girls. So be it any child with any deformity or any disease, one must check their height and plot it on a growth chart. Coming to complications, every child that has completed 2 years or more than 2 years and the age is above 10 years. So figures to remember: age above 10 years and diabetes duration above 2 years has to be screened every year for diabetic retinopathy, and this is how the exudates and hemorrhages in the retina look like. And one has to also look for the neovascularization. Retinopathy is managed with tight sugar control, and prevention is the best strategy, because once the retinopathy has happened, it's very difficult to reverse it. One can actually slow down its progression by tight sugar control and also lipid control, so by giving them statins and other drugs. So nephropathy, again very common in children with poor sugar control. So persistent microalbuminuria, that is above 30 to 300 milligrams in 24 hours. So these are the adult figures. In pediatric age group, we use something called as a spot microalbumin to creatinine ratio, and the range is less than 30. So if the value is less than 30 for microalbumin to creatinine ratio, it is considered normal, and one has to document this normal microalbumin level every year, so annually. So
2 minutes, sir. Sorry to interrupt you, sir. 2 minutes.
Yeah, sure. I'm almost at the end
Yeah.
of my talk. Yeah. So spot first passed urine is preferred, and these are the ratios. How do we treat these microalbuminuria patients? We generally ask them to have a tighter control. We give high quality protein. We don't restrict them, but then we improve the protein quality. And if tight control of sugar does not help, then we add ACE inhibitors for these microalbuminuria patients. Diabetic neuropathy is also very common, and you have to screen these children for neuropathy via checking their reflexes. Hyperlipidemia, one has to screen all children with diabetes above 10 years, and many of them will have derangements in their lipid profile. If the sugar control does not help in sugar control and diet does not help, then you have to treat these children with a statin. Atorvastatin has been recommended at the dose of 10 milligrams to begin with. So in summary, the SMBG or self-monitored blood glucose is the key towards achieving good sugar control and good HbA1c. Time in range is a new concept added in the monitoring of type 1 diabetes. Continuous glucose monitoring enables the caregiver to titrate the doses and to see the impact of various food substances on the sugar control. Screening for complications begins after 2 to 5 years of diagnosis of type 1 diabetes, and screening for growth failure and detecting growth failure on time is essential to prevent short stature and Moriac syndrome. So with this, I come to the end of my talk. I thank all of you for a patient listening, and over to you, Dr. Vani.
Thank you, Dr. Tushar. That was wonderful. You told us about you gave us a lot of information about the importance of monitoring in type 1 diabetes to prevent both acute and long-term complication. I think there's one question in the chat box. Dr. Srinath has asked, while tapering the insulin from IV to subcutaneous, if a glucose reading is high, how much of additional insulin should be given along with the normal dose?
Yeah. So I think this question was for Dr. Ahila ma'am. If she is not there, I can answer that.
Yes, she's not.
Yeah. So I believe this is a question where you are coming out of a DKA scenario and you're switching over.
Yeah.
So generally there is, what we do is in our practice is we give an overlap. So on the day prior, we give a long-acting insulin like Glargine in the night, and in the morning at breakfast, we switch over. So that prevents the kind of rebound that we get after starting them on oral. Secondly, we take into consideration what amount of insulin the child required over last 24 hours, and we take that as a baseline, and almost 50% of it or 40% of it we give as a basal, and remaining 60% we divide initially in equal amounts of boluses. But then if the sugar reading is high, we can add some 10 to 15% of extra bolus into that.
Extra.
We also take into the consideration what food item the child is going to eat. So in total, the correction dose plus the food bolus to prevent further high sugars. Thank you.
Thank you, Dr. Tushar. Over to Dr. Monica.